My daughter sent me a
Hello,
picture.
everyone. We're going to go ahead and get started with our session. This is the Recruitment and Retention Committee meeting, and we will also have a Take Action series presentation as well. I'm Allison Caban Holt, and I am the chair of the Recruitment and Retention Committee. I'm going to give a brief RRC, which is what we call ourselves, a brief update. And this may be information that you may have heard at other meetings, but we're going to give a brief update on some of the diversity, equity, and inclusion initiatives that are going on right now, and then we will segue into our panel discussion. So while cancer impacts all of us, clinical trials to improve cancer care and outcomes do not currently serve all of us equally. And from last time, I also wanted to share that we have a diversity imperative, and that is an agreement with all of us that we think that as the research community, that we have to be willing to agree that we are not doing everything that we can to be inclusive. And that really shows in the numbers of participants who are part of our research who are from diverse backgrounds, and that we need to be able to look at barriers and make corrections for those barriers. Some barriers may be financial, but we also really need to look at how we can make change not after the fact, not after the protocol has been written and the budget has been determined, but on the front end, because it's important. It's important for us to be able to be inclusive. It's a scientific imperative as well. In the past year, SWOG and the Hope Foundation for Cancer Research, in collaboration with Genentech, have launched a multi-phased, multi-year initiative to improve diversity, equity, and inclusion in SWOG and amongst our leadership, membership, and throughout our cancer clinical trials. So this is a slide that we used at the last meeting as well, and I just want to give you an update. So some of the structure and organization that we are putting together for diversity and inclusion include, of course, the Recruitment and Retention Committee and our Diversity, Inclusion, and Belonging Strategic Working Group, which we also call DIBS, the Patient Advocate Committee, and SWOG members, because we all play a role in making sure that we have inclusive trials. But the items in red were new at the last meeting, which include I guess they were new at least a year ago, because we have our DEI fellow, we have our champions, the monitoring committee, advisory board, and our vice chair for DEI. So our advisory board will be assisting the chair, and will be providing advice and guidance to support the chair. So that's actually to be developed. We're in the process of doing that now. But Dr. Don Dizon has been named the Vice Chair for Diversity, Equity, and Inclusion and Professional Integrity. And he's going to be accountable for and empowered, which is important, within and across SWOG to make change that will assist in diversifying the leadership, membership, staff, and the representativeness of our trial accrual. So we're excited to see him named. That's been quite a while in coming, and that Dr. Dizon has both experience as well as a passion for this work. Of course, our RRC, as you know, we have our DIBS working group. And as the RRC, I don't want to go into that for too long, but our RRC, we are promoting, in our DIBS, we are doing things like this Take Action series, and we're going to work in concert with the vice chair of diversity and inclusion and the advisory board in order to ensure that we are moving towards diversity in our clinical trials. We have the implementation fellow, who is Dr. Patricia Robinson, and recently she completed her one-year progress report and has been making good strides with regard to working with the DEI champions, and has developed a survey for the membership. Our champions are now in place and have been working for a while in their respective committees, and several of them are here today. So our champions have been working hard. It's taken a while for them to get up to speed and to be able to determine what are going to be their goals for each of their respective committees, but they've been working hard and have made great progress. The Diversity, Equity, and Inclusion Monitoring Committee, that has begun. The members have been selected. It's a diverse group. The committee has been formed. They're in the process of determining what their goals are going to be, and they have named co-chairs for that at this point. So overall, many of the diversity, equity, and inclusion efforts in SWOG have made great progress in just 1 year. We want to invite you to our Diversity, Equity, Inclusion meet and greet. That's going to be Friday at 4:45 to 8:30, and that's going to be in the Crystal Ballroom. And I've been informed that there are going to be lots of goodies there, so please come. And the purpose of the meet and greet is for us to bring like minds together, people who are all interested in doing diversity, equity, inclusion work, whether you are currently doing it or have an interest. We'd like to have folks meet and learn about what others are doing so that we can combine efforts. I think one thing that has been pretty clear as we have been opening up this work is that there are people in lots of different pockets doing similar sorts of things. It would be great if we knew who all and what efforts are going on so that we could be more coordinated, and rather than be redundant, but to enhance the efforts that we have going. So that's the end of the RRC committee updates. Now we're going to move on to our Take Action series, and it was developed by our education subcommittee, and that is Kamara Mertz Rivera and Lucy Gansauer. So we really thank them for all of the work that they have been doing to coordinate this Take Action series. So far, we have had equity in African Americans was the first one. Then our second one was looking at Asian Americans, and the last one back in the spring was looking at American Indian populations. Today, we will be looking at ensuring equity in clinical trials with regard to our Hispanic, Latino populations. And in the spring, we are looking at the LGBTQ community as our next focus. Just briefly, cancer is the leading cause of death among Hispanics. And so we think that this is a very important and relevant focus for the work that we're doing. And we have an illustrious panel. I'm going to introduce the first couple of panelists. So we have Dr. Jonaida Rivera. And Dr. Rivera is an assistant professor in the Department of Communications at Rutgers University and focuses on health misinformation. She is an associate member of the Cancer Institute of New Jersey's Cancer Prevention and Control Program, and was a community health educator through the NCI's Cancer Center for Reducing Cancer and Health Disparities. We also have Dr. Barbara Segada Vasquez. Dr. Segada Vasquez is a professor at the Medical Sciences campus at the University of Puerto Rico. She is a two-time breast cancer survivor and is very active as a research advocate. She's a member of SWOG's Cancer Network Patient Advocates Committee and the Cancer Care Delivery Committee. And then I'm going to ask Lucy Gansauer to come up and introduce our final speaker.
Thank you, Allison. It's my pleasure to be able to introduce Dr. Gary Uzikti. I've known Dr. Uzikti for many years. I got it?
Anxiety.
Anxiety, sorry, from Alliance. And I'll read his formal bio, and then I'll tell you a couple things about him that's unique. He's the only breast surgeon serving the Laredo, Texas community that is 95 Hispanic. He has enrolled more than 1,200 patients on clinical trials as a sole practitioner. He was awarded the ASCO Clinical Trial Participation Award, Doctors of the Hospital of Laredo, 2009 and 2014 and 2018. He received the Richard Silskitsky Achievement Award, and in 2020, the ASCO Humanitarian Award. Monica Bertinoli actually visited his site for 3 days because of the extraordinary work he does. And I was asking him about his accruals, which we know are extraordinary. And I said, now, how many follow-ups are you managing? Because as we all know, breast cancers, the follow-up is very long. He said he didn't know, but he has about 2 or 3 every day. And I said, well, how do you manage that? He said, I have rave open all day. He does all of his own rave. Recently, he's now started doing all of his own regulatory because the hospital lost their regulatory person. He even helped the hospital with the FWA. He is a one-man show that doesn't see any barriers to achieving the important work of clinical trials. Thank you.
All right, so our first panelist is going to be Dr. Jonata Rivera, and she's going to be talking about understanding Hispanic Latinx populations.
Can you guys hear me okay? Yeah. Thank you so much for the invitation. Thank you, Kamara and Melissa and Allison in particular for coordinating all of this. So I am going to be talking about something that's very big with a lot of important topics. So I will preface everything by saying that this is a bird's-eye view of the issues that impact Latinos and Hispanics in the US. And I'm sure that during the conversation and after the other 2 great panelists, we'll have an engaging conversation about all of those things. Now, I want to start off by saying that if there's one word that I want you to take away today is heterogeneity. We are a very heterogeneous group here in the US, and I am going to be talking about different aspects that are important when you think about trying to target Latino audiences, understanding a little bit about our identity, about the factors that impact our health outcomes, and then I'll give some examples from my work in cancer information and misinformation on social media to kind of tie all of those concepts together, and then I'll give you some strategies for how you can kind of start identifying different Latino constituents in your communities. I will be referring to the group as Latinos probably throughout the conversation today, but please know that when I say Latinos, I am referring to Hispanics, Latinos, Latinas, and Latinx, and I'll talk a little bit more about those differences in a few slides, okay? So let's start off with acknowledging that the US Hispanic or Latino population is incredibly large. It reached 62 million in 2021. According to the census. And as you can see on the map on the right, I don't know if it's clear or not, there are a myriad of states where Latino populations are among the largest minority groups. In California and Texas, they actually surpassed non-Hispanic whites as well, so they are the largest group. And in the states that say 8 through 13, those are all states where Latinos are at least 1 million of the population. So definitely a really important and big constituency that we want to be tending to in this country. And just highlighting that, we saw with the 2020 census that Latinos account for over half of the country's population growth. It's so hard to see the slides from here, sorry. I think I actually might peek at these if you don't mind. Thank you. There we go.
Oh, that's
I'm
better.
gonna,
Yeah.
now that I put it,
Oh, thank you. Thank you very much. Much better. So Latinos make up more than half of the total US population growth, as you can see here, grew over 52%. But we tend to kind of always refer to Latinos as a conglomerate. As you can see here, though, there are many different groups of Latinos. The top 5 groups of Latinos here in the US are Mexicans, which encompass almost 60% of the Latino community. Those are followed by Puerto Ricans, 9.3%. That includes Puerto Ricans in Puerto Rico, as well as those here in the mainland. And then Salvadoran, Cuban, and Dominican are the next 3 groups. Now, when we think about how to identify groups and ensure that we are talking to them, so caveat, I am from a School of Communication and Information, right? So understanding your audience is really important to ensure that people are attentive to the messages that you are trying to give them and the education. And in the case of everyone here, right, we want to enroll Latinos in clinical trials because that's so important. So it's important that we understand how they identify themselves. As you can see here, Latinos have mixed views on how they describe their identity. 47% actually describe themselves from their country of heritage. I identify first and foremost as Puerto Rican, and I personally identify as Latina, but others might identify as Hispanic. And the difference between those terms, Latino is someone who is of Latin American heritage, that includes Brazil and Portuguese speaking. When we say Hispanic, that is someone who speaks Spanish, which also includes Spain, right? So we tend to, I identify as Latina, but as you can see here, only 18% of the US Latino population use that particular term. Most have no preference. But another thing that's really important is that now that the census has changed how some of the data is collected, we've seen that US Latinos are multiracial, and they actually show that in the way that they define themselves. So most Latinos identified as having 2 or more races, or as having some other race, not just as white, Native American, Black, or Asian. And those aren't the only things that are important for us to highlight in terms of Latino identity. This is where being familiar with intersectionality is really important when dealing with these audiences, right? A person can identify as Latino, but they can also identify as Afro-Latino. And what we see is that about 2% of the US adult population and 12% of Latino adults identify as Afro-Latino, right? We also see that ancestry and how individuals identify, whether they identify as Latino or Hispanic, also changes with generations. So we're seeing the complexity of the patterns that we have within this community. And again, that's why it's really important to speak to your constituents and make sure that you understand what audiences you're trying to reach. Now, the term Latinx, I get a lot of questions about this. Latinx is a term that is intended to be gender neutral. And we definitely are using it a lot within academic spaces, clinical spaces, as a term of inclusivity, which is incredibly important, given that Spanish is a gendered language. However, within the general Latino population, as you can see here, these statistics are from 2019. They might be a little bit different now, but only 3% of Latinos who've been surveyed use the term Latinx. Another 20 have heard of it, but most haven't heard of it. and a lot don't necessarily identify with that term. I will point you to a really great piece that was published in the American Journal of Public Health discussing this particular term. It is incredibly important, especially if you're working with and for communities who are gender neutral or who identify as transgendered, et cetera, right? Being able to have language that is inclusive. But we have also seen an uptick of research that kind of brings this in as a buzzword. I personally like to identify groups as Latinos, Latinas, Latinx, right? There's a difference and options, and inclusivity is the goal with this. Now, I also wanted to note that you might see Latine as well. This is actually what some groups tend to use in Spanish because it sounds a lot better. Latinx is definitely not something that rolls off the tongue in the Spanish language. So, of course, I can't talk about these topics without highlighting the fact that cancer is the leading cause of death. As Allison was mentioning, these are statistics from 2019 from the American Cancer Society's cancer statistics about Latinos and Hispanics in the US. Of course, it's also important to note that in 2020, COVID was the leading cause of death among Hispanics. And a lot of those reasons have to do with some of the factors that I'll be talking about in a few minutes. But before I do that, I want to briefly highlight, because I know another panelist is going to be talking more in depth about this. We tend to use a lot of statistics that conglomerate these groups, but as you can see here, this is a study that was done by Dina Martinez-Dyson at USF, looking at cancer mortality rates among Latinos by gender and subgroups. And as you can see, there are definitely differences by subgroups, right? When you look, the green line is all Hispanics. Mexican Americans and Mexicans in the US tend to be similar in those rates to the entire Hispanic population, which makes sense, right? They're 60% of the population in the US. But then when you look at, in breaking them out, Puerto Ricans and Cubans actually have higher rate. I'm sorry, yeah, I believe it's Puerto Ricans and Cubans, yes. So again, it's just very important to, when possible, not lump these groups together because there may be very unique instances and behaviors that impact their health outcomes. So now I'm going to pivot a little bit to talk about considerations that you might want to consider when addressing health among Hispanic populations. And this is not an exclusive, this list does not have everything. These are some of the more important things that I'm going to briefly highlight with examples. So we want to make sure that we are thinking about the role that cultural values and norms have in Latino audiences, ways of communicating and addressing health topics. We want to be cognizant of differences in acculturation levels, which also encompass language preferences and immigration status. Of course, from a social determinants of health perspective, we definitely want to ensure that we're taking into account different constituents' socioeconomic statuses and their healthcare access, which is going to be influenced by those previous factors that I mentioned above. And then I also want to highlight a little bit about differences in medical trust and mistrust that audiences may have, and with communication environments, because if you want to accrue and reach these audiences, you need to understand how they're using different communication methods to be able to retain them in research. Cultural values and norms. I want to preface this by saying that these are shared values that aren't unique to Latino audiences. Latinos tend to have collective worldviews, more so in Latin America. So they're not exclusive to, but they are important to different Latino groups. And these values, even though they may manifest in different ways based on acculturation and other factors, are important values that we see across the board in Latin American communities and countries. These stem from our historical background, right, as Spanish colonies. Catholicism is very big in Latin America. So when we think about these terms, I just want to define them briefly without any valence. So Marianismo and machismo get to more of these gendered roles that we might see in Latin American communities. Machismo is, I guess I would define it as this assertiveness, which may have negative ramifications in health outcomes, but may also have positive. We've seen literature that supports both as a part of that cultural identity and how it gets manifested. Marianismo is kind of the opposite. It's more of these Virgin Mary type of attributes that some Latinas may have, where they are not necessarily more submissive, but they are wanting to respond, respond to, and this sense of virtuosity, etc. So these values may make it difficult for some communities to get access to care because of negotiations between partners, etc. Fatalismo gets to issues related to this idea that everything is predestined and predetermined, again, stemming from more of this Catholic kind of background and heritage. But at the same time, we've seen literature that sees fatalismo as both promoting health checkups, etc., because God is in control and the physician, right, has the training that God gave him. And you may also see it as people who don't want to engage with conversations about cancer because that might bring upon negativity. We also see other values like familismo and personalismo, which emphasize the importance of trust and community in Latino audiences. So the importance of family, the importance of being respectful and caring to those interpersonal relationships that you may have with friends. All of these things have been shown to have protective factors within Latino audiences and different communities based on acculturation level, etc. But at times may also make it a little bit difficult to reach these audiences. Now, acculturation is another important topic to talk about, and acculturation, a lot of this work has, I will refer you to the work from Ana, oh my gosh, I blanked on her name, Abraido Lanza from Columbia University, who does a lot of work on acculturation. And she defines acculturation as a process by which individuals adapt to a new living environment and potentially adopt the norms, values, and practices of their new host society. There's a lot of work that's been done in acculturation. Some of the overarching findings is that we can see that acculturation has been shown to have both negative and positive influences in health outcomes, depending on the audience and depending on the health outcome. So we've seen in literature supporting a negative influence on smoking, alcohol consumption, nutrition, diet, more of these behavioral factors that have to do with promotion, right? And then we've seen it actually have a positive influence on healthcare access and services, right? The more accultured certain groups are, which leads to some of the other things I'll talk about, right? They might have healthcare access because they're now eligible for it, et cetera. So these things have definitely been influential, but I will point you to her work for more depth. Of course, alongside acculturation, language preferences are very important. As you can see here, Latinos have actually, we've seen that English proficiency has increased along the years, and we've also seen that depending on the group, there's a bilingual, bicultural element, or people might actually continue within their enclaves to just practice one language or another. This is going to impact things like access to adequate health information, making sure that you're able to communicate with your constituencies and that they feel comfortable with that. Immigration status is also something that's important. We've actually seen that the share of immigrants has fallen in the last few years across the board, right? And we also see that immigration status, and especially for undocumented immigrants, this is going to be a really important factor to consider when reaching them for different prevention and care services. In terms of socioeconomic status and healthcare access, when you segment by subgroups, you see that there are different rates as well. And I want to briefly talk about medical trust and mistrust. So it's really important that we acknowledge that a lot of the factors that I mentioned previously build into conversations about trust and mistrust, and that mistrust isn't all about misinformation, because that's the buzzword that we're talking about a lot now. There are some genuine reasons why different groups of Latinos mistrust the medical system. They might not see themselves in the providers that serve them. They might feel like they can't communicate with them. There have also been groups like Puerto Ricans in the 30s, 40s, 50s who were forced to be sterilized, who were used, or who partook in birth control pill trials without knowing, right? So there's a lot of mistrust that is warranted, and it's important to acknowledge what those things are and how to navigate those conversations when we are going to educate them about these different topics. In terms of the communication environment, this is also really important because Latinos actually use social media, streaming services a lot, and at higher rates than the general population. So these are really important places to identify in terms of how to reach out to the audience. And this becomes important because I'll show it in the next slide. Latinos actually relied on social media heavily. 57% of Latinos reported using social media during COVID to actually find access to information. And it's really important that we understand who they trust and how to get the information to them through those trusted sources. As we can see here, there's still trust in experts, but there's also a lot of trust in community, in friends, in certain groups that we can kind of use to our advantage when we're reaching these audiences. So I'm going to give a quick example of this within the context of health misinformation, which is the work that I do. As I mentioned, Latinos rely on social media a lot, and we can see trends at the bottom. They use different platforms much more than other constituencies. And this is some of the work that I was wanting to explore in terms of, okay, we have this audience who's using these different platforms. How are they engaging with content related to cancer prevention and screening information? How are they assessing the credibility of this content and making decisions about the work or about the information that they're consuming? I'm not going to go into too many details about the research because I want to be cognizant of time. But let me squeeze over here. So some of the findings that I saw that were really important is that a lot of Latinos, when engaging with content, most of which was not evidence-based, they were using culture and stories, narratives as ways to assess the credibility based on heuristics that aren't necessarily going to provide the accurate guidelines for whether or not content was actually credible. Culture is influencing the interpretation of how people navigate this information, and it can lead to negative consequences. This is an example of a participant who saw a video of a physician, someone she thought was a physician of Puerto Rican descent, saying that mammograms cause cancer. She called and she canceled her mammogram, right? This video was an example of all of those different things coming in. She was a Spanish speaker, she preferred Spanish, she felt like that person was identifying with her, and she proceeded to make a decision about her clinical outcomes because of this. So, however, another thing that I saw that's really important that will bring us to the closing slides is the role that sources have in how people navigate information in these different environments. So we saw that a lot of the people who I interviewed were giving just more importance to the source if they thought that that was a trusted source within the community, and whatever that source was sharing with them would be accepted as true, as credible. So that is something that we can definitely use to make decisions about how to reach our different audiences. And I'll end with some brief slides and strategies that we can pick up in the Q&A to identify different Latino populations. So one thing that is important is to understand relevant audience segments and elements that are important to their identity. So you have to go out there and talk to people before doing this. And these are just some examples of the kinds of questions that we think of to do an audience analysis and segmentation, right? How does this group identify? What words do they use to identify themselves? What characteristics are predominant? Who are the trusted sources of information, and what resources do they use? How does this group use media generally, but also to engage with whatever health topic in the case of clinical trials, right? And cancer, how do they engage with this content? How do they process information? And I didn't go into things like digital literacy, political affiliation, trust, but those are also important factors. And then the last two things that I'll lump together is the importance of utilizing people on the ground who already know this community. Building partnerships is instrumental, be that as identifying promotores or health educators, trusted leaders who already have face value and trust within the community, but also identifying different organizations that can serve as gatekeepers that can help you reach these audiences. So when working with these communities, remember that listening to community leaders and working around their needs is instrumental for success. You want to ensure that efforts are culturally sensitive, that initiatives are engaged, active, and use trustworthy community partners, and that communication with these audiences is consistent and trustworthy. And you don't want to just show up and then leave afterwards, because that builds more mistrust in the system. So I'll leave you with that, and I look forward to questions in the Q&A.
All right, thank you, Dr. Rivera. And next we will have, and we'll save questions for a Q&A time at the end. We have Dr. Barbara Segura Vasquez, and she's going to be talking about cultural strategies for working with Hispanic Latinx participants.
So good afternoon. Thank you for being here after being all day in meetings, and thank you for the Recruitment and Retention Committee for inviting us and addressing this important topic. There's a few slides that are repeated, so I'll go fast in it, but in general terms, we have heard that Latinos represent almost 19% of the population, and only 7%, 1 to 7% participate in clinical trials. We have heard in the last maybe year or year and a half, diversity and inclusion is a hot topic. And the other day I was in a conference as a speaker for, virtual, for Faster Cures. And one of the presenters talked about health equity tourism and caught my attention, and she sent me the link, and it's at the end. And what they see is how previously unengaged scholars capitalize on public's new interests on healthcare disparity. So This is a hot topic, and some of us are a little bit skeptic of what's going to happen because since the 90s, the government has tried to have more diversity and inclusion in clinical trials, but we are hopeful that it's going to happen. So these are the objectives mainly about what are the issues affecting the Latinos, the barriers, how can we engage, and facilitators to have increased participation. This is similar to what Jonaida already presented in terms of where the higher concentration of minorities are, and that Mexicans are the highest. And an important fact that 24% of the Latinos do not speak well English or do not speak English at all. So that is important. And approximately 20% of Hispanic are uninsured. So that is important as well. There are some health issues important to highlight because it's gonna have to do when we recruit, right? So from the CDC, obesity is 44% in men and 46% in Hispanic women. And hypertension as well is 46% in men and in women 35%, which is an important fact because those could be exclusion criteria, and then we're gonna leave out a huge percent of Latinos. This has already been shown, but it's important to mention that Latinos are less likely to be diagnosed at an early stage. So that's why when we see the incidence is lower than many non-Hispanic whites, but we have higher mortalities in different cancers. And usually it could be related to the low economic status as well as obstacles for screening and lack of access to those services. And even in survival, one of in this report, it mentioned that melanoma survivor, 5-year melanoma survivor in Hispanics are 78% versus 91% in non-Hispanic whites. So this is an important fact. This was also mentioned by Jonaida and Allison, so we know that cancer is the #1 death incidence, right? So another thing that Jonaida was mentioned, and I found this great paper preparing for this conference that is called Disaggregating Hispanic American Cancer Mortality. They did a study on 200,087 deaths among Hispanics, and they try to then disaggregate, and the first 5, lung, colorectal, liver, prostate, and pancreas were kind of common, but as Jonaida mentioned, when you lump them together, it could be diluted for some. So it's important to understand they are Latino, but where are they from? Are they Mexican, are they Puerto Rican, et cetera? So we can see here that for lung is first for all of them when you compare Mexican, Cubans, and Puerto Rican, but is higher in Cubans. And colorectal is a little higher, and in liver as well. You can see Puerto Ricans, Cuban is lower and is higher in Puerto Ricans and Mexicans, and prostate as well, and pancreas. And for Central and South American, stomach cancer is 7%. And it's associated maybe with the infection of H. pylori. And liver is among the top 5 in this population. And when they talk about disaggregating the data, and when we present the numbers of the American Cancer Society as well, when we talk about the habits, they were comparing, when you lump them together, it could be a lower percent, but when you look them individual, when they were asking, for example, Mexican, Cubans, how many drinks they have a week, it'll be 8.5. But when they asked, Puerto Ricans, it was 16.5 a week. So I sent this to my family. I said, we are very well representative, and we are better than Cubans in that sense, which we should not be, right? So anyways, And they also call the Hispanics Hispanic paradox because as decreased cancer burden, surprisingly, even if we have increased health disparity, and some of the theory is that it has to do with immigration of healthier individuals, and at the same time, sometimes when individuals get sick, usually go back to their home to get treated or maybe die. So those numbers are not captured and could be a paradox, right? Why is it important? We all know that many clinical trials for new cancer drugs didn't include any data of race, and in this report published in JAMA in 2019, they did a study from 2008 to 2018, and they found that Black and Hispanic patients in particular were underrepresented in trials that led to cancer drug approvals. There were far fewer Black and Hispanic patients in cancer clinical trials that would be expected. So we all know that's a problem. And this other paper was from Bethany from 2017, and it was an analysis genetic testing, and they found that 96% of that analysis of genomic studies was done in European descent population. And that is important when we are trying to move into, we have been moving into precision medicine and target therapy, and if we don't have the data and this population has not participated, the gap is gonna be even bigger. I found the other day somebody was in ASCO Quality and cited this site of internet fact that I have never looked at, so I went and looked at it, and it's really cool because they talk about different aspects of the internet and social media, and they have stats by race and ethnicity and age and all those things. So when they look at who has home broadband, Hispanic are the lowest percent of people who have home broadband. And this is important because if we're gonna do like telehealth and things like that, we're gonna see when we look at smartphones, Hispanics depend on the smartphone, right? So there's so much you can do with a smartphone. And I have a friend who's a psychiatrist, and during the pandemic, she was doing telehealth, and she said, I could see the difference between those parents that were trying to have, I had this session when their broadband was very low, or they were doing it at the phone. It wasn't the same, and she cannot provide the same service. So when we talk about remote access, we have to consider all these issues because it's not the same. Like Jonaida said, there's a lot of heterogeneity, and I try to practice the pronunciation, so forgive me for that. So when we talk about barriers and concern among Hispanic, first off is lack of information of the disease, treatment option, and clinical trials. I was diagnosed in 2003. I am a medical technologist. I've been working at the University of Medical Sciences campus for 20-something years when I was diagnosed. And even then, for me, was overwhelming trying to understand what cancer was. So let alone when you're diagnosed, when you have low economic status people, lower education, lower health literacy. So there's gonna be a huge barrier, right? We heard that, and I mentioned before, 20-something% of Latinos don't speak English well or don't speak it at all. So trying to navigate the system is gonna be very complicated. And communication is key. So language is a huge barrier, right? And when you put in the social determinants of health, that's another issue that affect this population. The study design, the way the study is designed, the duration, the frequency. We know that Latinos usually have one or more job, and also they have less pay off time. So if they have to have time off to go to their treatment, and then they would have time to go to clinical trials, it's gonna be financially burden for them. And I have a friend, and even it's common sense, right? She was gonna do a study on breast cancer patients after they finished their treatment, and it was an exercise trial, and she wanted them to come during the day for an evaluation and during the day for the exercise. And I told her, Letty, you know what? After we finish treatment, first off, we still have to go to our oncologists every 3 months or 6 months or whatever and do all these testing. I'm not gonna take time from my work that I already had taken because of my treatment to do an exercise, right? So she modified and had it after hours and things like that. So when we want to recruit this kind of population, this is important. In terms of language also, I found a study that it was talking about the impact of primary language on healthcare engagement, as indicated in clinical trial screening and engagement in the use of genetic counseling and communication via electronic patient portal. And they found that patients with low English proficiency had lower rates of clinical engagement, but they also have lower rates of odds of electronic patient portal engagement. And this is something that sometimes in the trials we use as a mechanism of communication, but we have to be sure that it's in the language that people understand and can relate to. And another article that I found was talking about using translator to deliver genetic testing result to Latino population. And they did a study how these translators were doing their job. And they found that because they knew the culture, they added words and things that were not given by the physician. So they were say, you have whatever, BRCA1 to give an example, but don't worry. They would add, don't worry, that is, we have new medications and things like that. So the validity of the translation is questionable. They added the cultural part, so that's why it's important to have that right. Other barriers, access, most of these studies has been done, clinical studies are done in academic and specialty centers, and these kind of Latinos do not have access for that. Exclusion criteria, I already mentioned, we have a high incidence of hypertension and diabetes. And so excluding patients with these chronic conditions is a missed opportunity to discover the effects of these medications in this population. And if we have a higher burden of that disease, and this population was not included, then we have a problem, right? There's psychological aspects, and Jonaida covered a lot of this, of fear and mistrust. Sometimes we are kind of lumped together with the mistrust of African American, and they say they go to Tuskegee, but it's other kind of mistrust and trust, as Jonaida mentioned. And physicians are kind of the person to go to, so that trust is a trust entity for the Latino population. Financial burden I already mentioned, and because they're uninsured and low income, when you live in, even middle class, trying to, when you're faced with a cancer diagnosis, even the deductibles and things that you have, it's unaffordable for many of them. And access to patient navigators. In Puerto Rico, we have maybe 2 cancer centers there have patient navigators, but the rest, they don't. So navigating the system, again, I knew about the science, I had the background, and for me was very difficult. And I'd never thought about a clinical trial or asked. So this cannot be a burden on the patients. They don't know better, right? It has to be the physicians that get involved and give that opportunity. And I wanted just to make a note about the language. In Puerto Rico, when we started the COVID vaccination, we, to date, have 97% of people of the population with at least one vaccine and 85% fully vaccinated. But it was a huge campaign in Spanish that was given, and people could relate and ask questions, so that made a difference. Facilitators are related to part of the barriers, but also researchers and staff should reflect, we talked about this morning, having coordinators and people who invite the patients that can talk to the language, right? Because interpreters they do their best, but it's not the same, right? It's very important, and Jonaida mentioned it, partnership with the community health centers and NGOs, because they are the people where, the places where people go. Availability of materials in appropriate language and feeling, right? Have a picture or that people can really relate to that culture. Incentives and compensations, and inclusion of family members, and Gary's gonna cover that when he mentions when he recruits for his clinical trials. How to engage in Spanish, Hispanic and Latino in clinical trials? Well, education, and one of my main thing is we have to educate the community even before they get sick, right? Because when you're confronted with cancer diagnosis, you're trying to understand what cancer is, and at the same time, they want you to understand how clinical trials work. So we have to do better in that part and try to have educational pieces and information, right? We have to share stories, and Jonaya mentioned it. Latinos, we're all about the stories, and Share is a Latina organization in New York, and they do novelas because there's still a lot of people that like novelas, and they have these little stories that people can relate to. And talk to your patients about clinical trials in lay language they could really understand. These are resources that are already available in Spanish. FDA has a whole site, and I have the reference there, and the reference of the slides is available. So they have little videos and information in Spanish about, and with people, Hispanic people there, that about clinical trials. So it's a resource that you could all use. And from our own house in SWOG, Jonathan, who works he's part of the Patient Advocate Committee and the Digital Engagement Committee. He was talking this afternoon of a video that he did with subtitle in Spanish, and he found how engaged the Latinos, supposedly Latinos, because they were doing the Spanish, the one with the Spanish subtitles. So we have to do better in that part. Strategies, it goes, we have mentioned, but culturally tailored materials, communication, community education and our outreach activities, availability of patient navigators. The other day when I was invited to the White House about the cancer moonshot, one of the things they want to assure of the goal is to have patient navigators in every center, and that will make a difference, again, because navigating just treatment is an issue, so having a patient navigator that can help you find a trial and work through it is imperative. And social media platforms, as Jonaida mentioned, are important, and is a source for people to look at. Other strategies, incentive, like, because we mentioned they live pay to pay, so lunch, parking, child, taking care of their children, flexible hours, again, because they work double shifts, so have a recruitment on Saturdays or after hours, and then liaison with the community. Jail Cancers is in clinical investigation is collaborating with an organization called La Junta, and they have a huge Puerto Rican community over there. And what they do is when they have trials or ideas, they present it to the Junta, and they have the feeling from the community of what they want to do. Again, if we want to increase diversity, not only in Hispanic, but in everything, it has to be beyond enrollment. We have to have more researchers that look results, research teams, study sections, research staff, recruiting physician, and of course, patient advocates, right? This was a paper that was studying that lack of representation, so I'm not gonna go into it. And this is from our own SWOG. There is a methodology how to increase diversity. And recently, in April, I think it was, no, a couple of months ago, ASCO came out with increasing racial and ethnic diversity in clinical trials, and it was a joint venture between ASCO and AAC. And I happened to be one of the patient advocates that was working with, we were the patient partners, and we have we're gonna write a paper on that diversity and the patient partner. But they came up with this list for general. And they also, if you go to the paper, they have already a training available for free for the staff that is called Just Ask training program, and it's about unconscious bias that you can access for free. So in conclusion, we know that Hispanic and Latinos are the fastest growing minority. Inclusion in research guarantees justice and scientific reliability. Individual and community education is key. We know, as Jonaida said, heterogeneity among Hispanic is important, so knowing where they come from, and very important because there's a difference, those born in the United States or the immigrants. The incidence and the way cancer develops is different depending on that. English, establish links with the community and include advocates, and there should be diversity in the workforce. So these are the reference, and gracias, and that's a beautiful island of Puerto Rico where you can see the garita. Thank you.
All right. Thank you, Dr. Sagara Vasquez. And last but not least, we have Dr. Gary Unzaitig, and he is going to be talking about research design and strategies for ensuring equity in clinical research for Hispanic Latino populations.
Thank you. Thank you very much for the invitation, and Lucy, for your introduction, was very gracious. I'm a breast surgeon. I live in Laredo, Texas, which is on the Mexican border, 150 miles south of San Antonio. It is the most Hispanic of the border cities. Laredo is 96% Hispanic. And a lot of the patient, I would say that maybe Spanish is the primary language for about 50% of the population, right? And they, at my office, we kind of ask before I meet them, what's your language of choice? Yeah, and so I think it's very important for them to feel comfortable. The other thing is, the average income in Laredo, family income, is about $50,000, but there are a lot of people under that. And one of the big advantages that we have in Laredo is an incredibly good public clinic that's federally funded. They have grants and things like that, but they accept anybody. All you need is a picture ID, and it can be a Mexican ID, so that there's no, like, you have to be American, you have to have a social security number, nothing like that. And that, I get a lot of patients from them. There's the breast and cervical cancer screening program, which is a combined state and federal program. So women who have no insurance or are underinsured can be evaluated by nurse practitioners. And if they need a evaluation for breast cancer, whether it's imaging or physical exam, they're referred to me. And a big advantage in recruitment is, in Laredo, the radiologists, there aren't any radiologists that really do any image-guided biopsies. So I see most of my patients pre-diagnosis, which makes it much easier to talk about what the eventual treatment might be, and also to talk about, like, research protocols that might be available and appropriate for them to participate in. The thing about Mexican Americans, and talk about Mexican Americans, is there's big families, okay? And frequently the entire family is involved. And so it's not unusual to walk into a room, kind of a small exam room, and have 6 people there in addition to the patient. And you've got to be comfortable with that. You've got to be accepting that there are going to be that many people. I tell a story about a patient, and the other thing with Latin families, in my opinion, is there's always a head daughter. It doesn't have to be the oldest, it doesn't have to be the youngest, but it's what we call the mandona, the bossy one. And she makes the decisions for everybody, whether they want her to or not. And so frequently she's there with her mother. She's the first one to come if there's only one person. And I was pitching a trial to a very nice elderly patient one time. And the daughter said, well, can you talk to the whole family? Because they're going to get after me if I make the decision. I said, okay, how many people? She said, well, it's going to be anywhere between 25 and 30 people. So I said, okay. And I said, okay, and I share an office with my wife, who's also a physician, so the waiting room is a good size. And I said, how about we meet at 6 o'clock after office? And so there was room in the waiting room. The entire family was there. And the lady and I sat at one end, and I explained the trial. And the lady really didn't have any questions, and it didn't take too long because the head daughter stood up and told everybody who was asking questions, that's enough, she's gonna do the trial. And and I still see her, and I think, like, it's actually, she's past her 10-year follow-up, so she's still with me at 90-something. So it's, to me, like, I also pick trials that work. I think, I know my patient population, I know my limitations and things like that. And with breast cancer, we are entering a phase, there are a lot of what I call de-escalation trials. So, the drugs have improved so much, and do we really need to, well, we've learned already, we don't need to do an axillary dissection in most people. We don't need to do mastectomies in most people. And so now we're looking at, well, does a certain population of low risk breast cancer need radiation after breast conservation, and or less radiation? And so these are trials that the patients understand. And I think too, it helps because I am in Laredo, and they're at home, and they feel they're in their own environment. They're not in a big medical center somewhere where they might feel like they're a number or get lost. I also use a comment, I'll explain it, that they check me out on the Comadre hotline before they come. What that means is Laredo is a population of about 280,000, but it's a small city. So anybody who comes to see me for the first time knows who I am, and they know people who I have treated. So it makes it very easy. Just a little background to why am I in Laredo. My wife is born and raised in Laredo, and we met at Northwestern undergrad and then medical school. But if I married her, I always was going to Laredo. There was no choice. It was difficult. My Spanish was not good when I first went. My high school language was Mandarin Chinese, so yeah, go figure. So I would say that, the biggest things are being culturally aware, and I would never assume that my patient who only speaks Spanish, who only had a grade school education, did not understand what I was talking about when I explained to her the clinical trial, because they do. They're all very smart. Once they get over the shock and the fear, I think all they want to do is get better in whatever way I recommend, and that's another big advantage with Hispanic patients is they treat you like, you're God, and it's not the right thing all the time. And sometimes you have to be careful of too much undue influence. But I think, there's all those factors, the family involvement helps.
Who's still a Snapchat?
It's not always easy, right? And a lot of breast cancer patients are young, and they have kids, and they have a lot of things to worry about. And having their mother and their sister and their aunt and their grandmother all there to help them makes a big difference. And also, like including them, and which is the really biggest thing, is including them, the family, in the decision helps so much. They make sure they make all their appointments, and they make sure they take their anastrozole, and they make sure, you don't have to worry that things aren't being done the way they should be. I'm kind of done, I think let's answer questions, see if anybody has comments. Yes? Okay, thank you.
All right, so. All right, so we're going to thank you, Dr. Unzaitik, for sharing with us what you do there in Laredo, Texas. So the first question that we have, so it's time for Q&A. Please put your questions in the chat, And we do have someone who will be going, just raise your hand and we'll Phil Donahue it, and she'll bring the microphone to you. But the first question was, what resources and support are available for SWOG investigators and sites to design and enroll Hispanic Latino populations in clinical trials? So if you would just share any resources that you're aware of that will help researchers.
So when a few years ago, the Patient Advocate Committee started community advocates. One of the first community advocates that we recruited is a Latina. She's not here with us because she's in another meeting. So we have, when you're doing trials, her and I are available to look at it and help. I don't know, they have been building resources, and I think that's why I commend you guys for doing this, because even though we are a high percent population, we have not done enough. And I remember sitting at the table the first time I started at SWOG as a patient advocate, asking Dr. Blanqui, do we know how many Latino has been impacted? Of course, I was interested in that. And our trials, and the answer was no, they didn't know at that time. So I think we have to start building. My slides are available, and I included a lot of the reference that I found, because I don't have specific experience. And one of the things that we found in the literature, that there have not been evidence-based information about how to recruit. Some of them is based on experience, but we have to do a trial there that we can tell people, this is the best way to recruit.
One question I would have, particularly around breast cancer patients, is that in talking about sexual health or birth control, is there a difference in your approach to the Hispanic patient that might be? Because I know that sometimes the barriers between providers is they're not sure the comfort level there. Do you have a different approach, or how is that handled with the Hispanic Latino community?
Well, my only experience is with Latinas, actually. And I I've never felt like there was a difficulty or, reticence by the patients to talk about it. Actually, in a cabinet, sometimes you do have to ask questions, especially I find aromatase inhibitors are not a fun drug. And so, a lot of times sexual issues they won't talk to me about it unless I ask, and I do. And then I have a cabinet full of lubricants and replens and things like that, because they don't know, so I think it's important, and I don't know that that's just a Latina thing, or all women in their 60s and 70s might not bring it up to me, but it's important to discuss. Yeah.
But the sad thing is,
Thank you.
there's not as many physicians as you are, right? And it is difficult, and Latinas, we are not too open about talking. And it's, the younger generation is different, but for people, 40, 50, 60, young 60 like me, it's difficult, right? And I have been in an aromatase inhibitor forever, and nobody has ever talked to, I learned because I go to these meetings and other thing, but and I had great doctors, but nobody ever sat with me to do that. So it's not done often enough, and it's part of empowering and having, and then involving the family, right? Because it's a partner issue, and if you don't involve the partner for them to understand the difficulties you're gonna go through because of the medication is also, so it's a good question.
Yeah, and just speaking more broadly, not necessarily only about breast cancer and how to communicate about some of these topics. Barbara was talking about the importance of narratives with the Latino community. That is incredibly important. There's been a lot of narrative style, culturally tailored narratives that have been incredibly effective because they use telenovela style formatting to discuss issues from a place of being able to transport the audience into the storyline, and having there's there's a video called Tamale Lessons for any of you who are interested in this kind of work. That was created in Los Angeles County because they had incredibly high rates of cervical cancer among Mexican Americans. And this culturally tailored narrative had different storylines from multi-generational, like Latinas talking about HPV and cervical cancer screenings, et cetera. And they were able to go from 38% to 81%, either scheduled or conducted pap smears. And these video approaches that are narratives kind of tend to a lot of those issues. So just being creative about how to reach maybe some of those more sensitive topics that are important in Latino audiences is always good.
And I had a friend whose mother was diagnosed with breast cancer. I think she was maybe 65 or 66. And so the peer-to-peer was very important. And so when she talked to me, she said, I want to have a reconstruction because I think, it's not a vanity thing. I just want to feel better. And I said, you're entitled to, right? So sometimes they are ashamed of maybe thinking about, that just having reconstruction is something, that is not, it's not the important issue. You should be saving your life or whatever. So that is not the vanity. Yeah. So it's important. That's why to have people that look like you or can relate and say, yeah, that is perfectly, it's a good approach. You should do that. You should see, what is comfortable. And I had another one who called me once, and because the doctor did not do reconstruction the same day of the surgeries, he was going to postpone it. And I said, that's your decision, but you should not do it because he does not want to do it the same day. You should get an opinion. If you want to wait, do it. So there's a lot of, we need to have more advocates and people to do that peer-to-peer for people to feel more comfortable, right?
Thank you. I'm sorry, I forgot his name. When the breast surgeon talked about that in a large Mexican family, there's a top dog who makes the decision. Is it also true for Puerto Ricans, Dominican Republicans, and also Cubans?
So when I was talking about cultural values, that gets to some of those family dynamics that are really important in a lot of these Latin American countries. That is common. I actually, when my grandma had breast and lung cancer, and we all had a WhatsApp group, and everyone was, putting their opinion about whether or not to give her pain medication, and if that was good, if that was bad, right? That is common. We see that a lot, especially with multi-generational homes. We see that a lot with especially here in the US, right? And here in the US, you see definitely perhaps the younger family member. It doesn't have to be a daughter, it doesn't have to be a son. Maybe it's a cousin, maybe it's a grandchild, a sister, right? A nephew, a niece, who is kind of taking all of that information in, and that's the gatekeeper that makes the decision with the family. That isn't the case everywhere, and of course that's where acculturation and really knowing your audience does come in, but that is something that we see time and time again within Latino families.
And maybe, as a physician or doing a trial, you should ask, do you want to have somebody else listen? Because first off, when if it's recently that you're diagnosed, you're kind of overwhelmed. So when I went to the appointment with my husband, I even forgot when he was there, like the doctor said, in 2 hours you have to have this and whatever. Or I went with my sister, the Mandona one that would be my older sister. And she's like, you have to, like when I was diagnosed, you have to tell the family. I said, I'm not gonna tell the family. Yes, you have to tell the family. So, sometimes they could be overwhelming. And as a patient, you can say, please don't let anybody in. Otherwise, you kind of need that support. Even if I had another patient, a lady that I learned, and she was gonna participate in a trial. So she took the informed consent to her house, and her sister read it, her husband read it, her daughter read it, And then she read it, discussed it with everybody, and then she went back and said, yes, I want to participate. So it is a family issue, and it makes us, those are the support chain that you're gonna have if you entitle this. And they're, even if you don't ask, when you have Latino people with there, I had a friend when I came from my chemo, she would take my kids to the movies, and another one came and cooked for me. And even when I had surgery, my surgeon was laughing because I'm a Facebook fan and I have a lot of friends. So my son, he was keeping busy just posting on Facebook. So I had first, for my second diagnosis, the surgeon and then the plastic surgeon. So when the surgeon finished, my son puts on Facebook, like if it was me, already the surgeon finished, the plastic surgeon is coming on, and my surgeon said, and he tagged me, and I said, impossible, she's on the table, she cannot be using the Facebook. So it was my son letting the world know that I was, so yeah, that's what we do.
And I want to add, because we kind of briefly alluded to this in our presentations, but this is, so Latinos, especially, Barbara, please correct me if I'm wrong. There's a deference to the physician, right? There is a lot of trust. It's more paternalistic, especially older groups. And that's where things like representation and cultural competencies become incredibly important as well. So having physicians who understand your culture, who look like you, who speak the language, who get you, then facilitates those negotiations as well. And then they feel like you're part of the family. So let me bring my family and let me have a conversation with you so that then I can go talk about whether or not I'm going to enroll in this clinical trial and make an informed decision as a unit.
And have staff, it doesn't have, you seem like a very committed person, but it is having staff that can really relate, right? So we don't have to have all the physicians or the researchers look like us, but try to have someone who's going to talk to you that really, and coordinators are super important, right? Because those are the people that are going to try to explain to you what it is. So having a translator or not understanding what is important to you, or can I bring my family? No, I have to talk to you alone. Those little issues are gonna come in.
I have one more question. Can you comment on what kind of alternative therapies, alternative treatments are percolating in the community?
I don't know. Like as like alternative, like complementary alternative medicine?
Yeah, alternative medicine.
Like guanabana.
Because each ethnic communities have different kinds of alternative treatments. Can you comment?
I can briefly just mention one that it was actually one of the images that I had for my research. So soursop is very common in Latin America, guanabana. I don't know if it has another name that others might be familiar with. And there is some literature showing medicinal properties to this, but there isn't enough literature to support claims of it being a curative property. And that is something that within not just Puerto Rican audiences, but other Caribbean and Latin American groups, I've spoken to Venezuelans, people in like the Caribbean, South America portion, whom there's, my grandma told me, and we know that this is going to cure, and then you have a lot of information that's competing with that. Some individuals use that as complementary, others use it as
That's what I think. I don't think it's a big issue in terms of just adopting that, but maybe.
No, like in the Mexican culture, and especially, where I live, there's a lot of recent immigration, and they grew up on the ranchos and things like that. So there's a lot of folk medicine, and it's something to ask always, because there are some things they should not be taking, like when they're on an aromatase inhibitor and things like that. For the most part, though, it's kind of just teas and other traditional things that people would use for illnesses that don't interfere with pharmaceuticals.
And we'll take one final question.
Hi there. So appreciate the talk. Was more than one final question, perhaps it's three with loaded questions. So first, I would like to say that full disclosure, Cuban and Mexican, and I live in Cuba and I live in Mexico and I live in the US. So I would say my experience that you can add to the cultural values that the patients become a sick role. They are in a what the physician wants me to do. We already discussed that. What my, dominadora de la familia wants to do, the ones, and they like to be a little bit on that sick role, unless you give them the power to take that, So it's something that I have. I'm a physician, I'm a medical oncologist. I have to start, providing power to those patients, because they always come already with decisions made by them for them, or expecting you make the decisions. So I don't know if that's a cultural value among groups. Secondly, it is more importantly, you start with the heterogeneity, and is SWOG to be prepared by providing cultural competence, clinical trials reference for Mexicans compared to Cubans, compared to Dominicans? Should be thinking about, hey, let's do different educational materials, because you're alluded to, everyone is a little bit of a different group. And so the other question is perhaps a more statistical kind of question, a statistical and ethical question. Should a statistician be thinking, yeah, they are Hispanic, not Hispanics, they are Black, they are white, they're Asians, or should they be considering different groups, one group? Those questions important for clinical trials, results, and statistics, and things like that. I don't know if those things are kind of discussed in the patient advocates, and so 3 comments, and thanks for everything.
This morning, there was that discussion, yes.
And when you talk about stats and they will come, that's why I think we are not included and we don't have the numbers, or it's not even reported, right? Because they say, well, we had 100 people and 5 of them were Latina, we cannot get to conclusions, but that's what we have to do different. And something we were talking this morning is, depending on what disease you are looking at, and who are your sites. So things that we were talking this morning, that we have to be intentional, even from when we have the concept of what we're gonna do. If it's whatever, if we're talking about stomach cancer and we saw that South American and Central American have a higher incidence, let's find the sites where the population has a higher number of Central and South American Latinos, instead of going to Texas where we have Mexicans, or Florida where we have Cubans and Puerto Ricans. So I think that is part of the thinking process that we have to do, from the concept to the design and delivery. That would be my take. I don't know.
In terms of your question about, right, like tailoring materials, et cetera, I want to make sure to say that it's okay to, at times, create materials that are geared towards a more general group of Latinos. I think that at times is appropriate. One of the reasons why that might be is, especially with social media, if you're trying to reach audiences on these different platforms, there's a lot of transnational and just sharing of information that's more about your geographical location. There's this I guess, idea of, as a Latino, as a Puerto Rican, that then comes to the US, I identify as Puerto Rican, but Latinos speak my language, they understand my culture. So I start to immerse myself in the broader group of what it is to be Latino, and things that music and certain traditions that we share. Then there's the targeted approach, which sometimes you do need, because you are focusing on a specific incident or a specific situation within your community, within your locality. And there, not just translating materials, but transcreating them is a term that you might see in the literature, where you're looking at the specificity of that particular group and the questions they have and the concerns they had and the misperceptions they have, and investing energy and time and tailoring there might be what is necessary. So you need to just spend a little bit of time understanding who it is that you're trying to reach, and then make those decisions accordingly.
And I'll just speak briefly to the issue that you were talking about in terms of statisticians and looking at different statistical analysis. I think it's something that we are engaging about right now with regard to SWOG, because in order to do those different analyses, you have to collect the information at the level of detail that would allow for the disaggregation of the data. And so I think, and you all can speak to it, so we have to make sure that we are collecting data that is going to allow for the various, looking at these various groups in detail. So I would just say that I'm not sure how often information is collected at that level of detail, but that is something that we need to do. And we've been certainly talking about looking at various ways that the government, some of their categories for capturing all of this so that we have some consistency. But that is a major issue. And yes, I think that we should at least be looking at those numbers so that we can, approach the different communities in an informed way, rather than grouping everybody together and assuming that the statistics or the outcomes for one group apply to all the others. All right, we are at the end, and I want to one more time thank our wonderful panel and thank Dr. Unzaitig, Dr. Sagata Vasquez, and Dr. Rivera for sharing with us. And we thank you all for sticking with us for a few minutes after the session. Thank you so much.
Sagata is a Catalan name, isn't it? You're